Good morning, everybody, and welcome to the Thyroid International Recommendations Online, fondly known as Tyro MDS here. I welcome you to the program this morning, which I think should be extremely informative and extremely clinically relevant for all individuals, all disciplines involved in the care of thyroid cancer. We are joined this morning by Dr. Alan Ho, who is presenting from Los Angeles, where he is a professor of surgery at Cedars-Sinai Medical Center. He is the director of the Head and Neck Cancer Program and co-director of the Thyroid Cancer Program. Dr. Ho has focused his research in thyroid cancer risk stratification, and in particular, the pathogenesis underlying lymph node metastases. And indeed, lymph node metastases is the topic of this morning's discussion, in which we'll be exploring the impact of nodal burden on the risk of systemic disease. Joining me this morning is someone who has probably the highest level of frequent flyer points on the Tyro platform. Dr. Shaha, who needs no introduction, is a colleague, a friend, and he also is a head and neck surgical oncologist at Memorial Sloan Kettering Cancer Center. He's widely recognized for his expertise in thyroid cancer management with 610 peer-reviewed papers. He is also widely recognized as a tireless and dedicated educator. It's for these reasons that Dr. Shaha was invited to join the Tyro Medical Advisory Board. And so, as usual, our program this morning will begin with Dr. Ho's presentation of his manuscript that was published several years ago now, but remains extremely relevant. And then following that, Dr. Shaha and I will ask a number of questions. And as always, we ask our audience to send in their questions, and I'll do my best to get to those before the end of the hour. So Alan, welcome. Thank you for getting up at a extremely early hour, and looking forward to your presentation.
Excellent. Thanks for the opportunity. It's a real honor to be here. I'm going to share my screen. I've had roots in New York and in the East Coast, so I'm delighted and excited to be back, at least virtually, and discuss something that I feel as if many physicians, clinicians, endocrinologists, and surgeons come across the idea that distant metastasis is possible, not common, but possible in a number of thyroid cancer patients, and how to address them and address them effectively. So I'm happy to discuss that today. My disclosures are not, I have no financial disclosures to report. The idea that thyroid cancer is a low-risk type of disease or cancer is well known. It's widespread. The idea that all patients should get a total thyroidectomy and radioiodine has changed remarkably. And the concept that mortality risk is extremely low is almost always true. Nonetheless, although the mood is shifting toward de-escalation, I can still think of patients of mine today that 15 years ago, at the beginning of my practice, would have had a much more radical operation, are getting away with a partial thyroidectomy, or even less in select circumstances. There still are a number of cases, approximately 10% or so, that are deemed high risk. What we deem high risk these days is also very different and depends on the context. It could be someone with a risk of death, someone with a risk of recurrence, someone with a risk of distant metastasis. It's important and essential to identify them, and in a small caveat to the momentum of our field, to not undertreat those particular patients. I actually think, as I see newly diagnosed patients, consults with thyroid cancer not previously treated, it is indeed a key challenge for physicians to parse out the high-risk variants from an otherwise low-risk population, such as in this photo of Where's Waldo. Anyone with kids would know that it's sometimes very hard and a game in some sense to identify Waldo from a sea of otherwise normal people in the audience. There are important matters of distant metastasis in a select number of patients with thyroid cancer. It's not so rare that it's outside the realm of normal to discuss it. Unfortunately, there are not a lot of key factors to identify who would have distant metastasis versus not, but it is important to note that distant metastasis is likely a primary driver of death from thyroid cancer itself. What do I mean by the fact that it's hard to discern who has such issues? Well, first of all, thyroid cancer is a bit of an anomaly. It's a mystery that in some ways that there are really no easy molecular markers for thyroid cancer mortality risk, other than perhaps the mutations BRAF and TERT, and only when they're together. All the other mutations, such as RAS and NTRK, et cetera, they tend to more be used for diagnosis of thyroid cancer, not diagnosis of how aggressive that thyroid cancer is. There are other very commonly understood risk factors that have been identified, including some identified by the pioneering work of Dr. Shaha and Dr. Urken on this call. They include advanced age, low RAI avidity, enlarged tumor size, but by far the strongest variable, I feel is distant metastasis that deems someone who with a 99+% chance of being alive at 5 years to approximately 50% at 5 years, depending on the age. This is one article that has shown the challenges associated with distant metastasis. Dr. Shaha's group at Memorial, spearheaded by Ian Nixon, one of my colleagues and co-fellows at Sloan Kettering, looked at their vast database of thyroid cancer patients with distant metastasis identified on initial diagnosis. So 52 papillary thyroid cancer patients were analyzed. Again, this is a decent number given that in general they found that only about 2% or 1.7% of patients of all their cases were found to have distant metastasis, but another 1.2% had distant metastasis within 6 months of diagnosis. So about 3% of all their cases within the initial perioperative period were found to have this. So again, a small number, but given how widespread thyroid cancer can be, it's a common enough scenario. Their predictions of poor outcomes were age of a certain above 45 years old, extrapulmonary metastases, and follicular carcinoma histology, all predicting or associated with a higher mortality rate. Their 5-year disease-free survival for thyroid cancer is fairly abysmal at 46%. So that has made our team or our group wonder how to identify distant metastasis. And there are a number of mechanisms that we do in our field, but as a bit of a head scratcher, we oftentimes don't even bother to look until after the treatment, in most cases, surgery has begun. We identify distant metastasis usually through something on the lines of a whole body scan with iodine 121 prior to giving radioiodine, but this is given after surgery. It can also be detected with high levels of thyroglobulin, which is again obtained after surgery, for practical purposes. For certain high-risk patients, at least at our institution, we will get something like along the lines of a chest CT, but this is fairly rare to get before surgery and is somewhat crude because it may identify small benign lung nodules or other disease that is difficult to distinguish from true lung metastasis. You could also get a PET CT, which identifies disease in a more particular way, especially if it's FDG avid. But that's also problematic because many thyroid cancer metastases tend not to be avid at all in regards to FDG. And again, it's very rare, almost exceedingly rare to get that before surgery. But some information that we do have in advance before any treatment begins includes heavy lymph node burden and bad histology. So we've begun to wonder if lymph node burden is a gateway to distant metastasis. It's very natural and intuitive to think about it that way. Cancer or thyroid cancer seems to easily and exceedingly easily spread through lymphatic channels. There's oftentimes a number of patients where they have a high number of lymph nodes that have cancer in them, or we find cancer in the lymph nodes without even really anticipating it. What is true is that lymph node burden has had a mixed role in staging and prognosis, especially for younger patients, where lymph node metastasis is not as important or critical a factor for prognosis. But I think most people would understand that if it's going to spread to the lungs or spread elsewhere, many times a herald or a signal that's beginning to happen is if there are a high number of cancerous lymph nodes in the region of the neck. So I think it's overall an understudied metric to perhaps counsel patients if they have something like this CT scan to consider for counseling on prognosis and expectations about their overall prognosis, and perhaps not just with survival, but also with whether something is spread outside the region. We also wanted to consider, at least account for, aggressive histology. This is another perhaps well understood, but perhaps understudied idea that you could have another predictor for distant metastasis. A paper we looked at in 2020, looking at mortality risk of aggressive papillary thyroid cancer, shows us that from the very well differentiated or low risk kind of cancer all the way to along the spectrum to poorly differentiated insular and anaplastic thyroid cancer sees a gradual increase along M1 distant metastasis prevalence. This makes sense. The more dysregulated, the less differentiated the biology, the more likely there will be aberrant signals that resist radioiodine and enhance potential for distant metastasis. The issue with this paper is that yes, there is a higher incidence of distant metastasis over the less differentiated histologies, but this could also be accounted for other factors such as T-stage, extrathyroidal extension, etc. So there's distant metastasis is not necessarily exclusively because of the biology of the disease. In addition, it's very hard to study this because distant metastasis spread and these rare histologies are rare. They're hard to study, at least within the confines of a single institution. So this is where a National Cancer Database steps in by looking at a large-scale multi-institutional database. It achieves what single institutions simply cannot. Yes, it's highly imperfect, very imperfect. It has a lot of issues with being retrospective, being prone to coding errors, and there's a lot of data that's incomplete. But by far and away, it is highly powerful statistically. It's very large scale, and it's ideal for rare cohorts such as distant metastasis. It represents about 70% of newly diagnosed cancer cases in the US and is collected from over 1,500 facilities commissioned or sanctioned by the Commission on Cancer. So although there are papers that perhaps don't use it very well, but if it's wielded properly, it could honestly be a very effective tool to look at these kinds of questions. Many people ask me what the difference is between SEER and NCDB. I think that they're designed for different purposes, but whenever we look at the same question with both databases, we find that the answer is always the same. So in such large scale situations where the p-value is always going to be less than 0.001 and you have a high number of patients that lead to a low confidence interval, many times you'll get similar answers. And that just validates some of the research projects and the idea that a large-scale study could be achieved. SEER is designed for epidemiology, incidence, mortality, and cause of death. It actually only covers about 28% of US cancer patients, and that's because it's designed for health overall, so anything due to like diabetes or high blood pressure, not just cancer. It's missing key variables, including surgery, chemotherapy, and radiation, whereas NCDB is perfected for cancer overall. It's designed for surveillance, treatment, and quality. As I mentioned, it covers a high number of US cancer patients, but the problem with it is that it looks at survival only. It doesn't look at cancer-specific or disease-specific survival. That's a limitation because overall survival could be from dying from old age, a heart attack, a stroke, many other things. It's hard to distinguish what's from cancer. All right, so our paper looked at a 13-year interval, nearly 48,000 thyroid cancer patients with complete data, and we focused on multiple histologies, most overwhelmingly well-differentiated thyroid cancer, but also some of the more rare ones that we may all come across over the course of our practice: sclerosing variant, tall cell, poorly differentiated. And we included anaplastic thyroid cancer, even though it's not papillary thyroid cancer, it's an excellent comparator. Here is the breakdown of our results. By far and away, the most common variant was well differentiated. 82% of our cases were as such, whereas only 463 were diffuse sclerosing. This is a very relatively rare condition. Tall cell was focused upon, as well as poorly differentiated thyroid cancer. And again, as a comparator, we looked at anaplastic thyroid cancer as well. Nearly 57% were T1 in terms of T stage, and nearly 75% were N0. So many of these patients were later removed from the analysis. But the overall prevalence for distant metastasis, and again, this is at diagnosis, not later, was about 3.8%. Stratified by histology, we see results similar to the paper that I mentioned earlier. As you become more dysregulated and less differentiated, the incidence of distant metastasis begins to rise. We also looked at patients who were N0, again, to show that lymph node metastasis is not by itself the only sole predictor. And although the numbers are lower, there are cases of N0 patients jumping to distant sites. So it happens less commonly, it's more rare, but it can definitely occur. Perhaps a limitation is that some of these patients that seem like they're N0 perhaps never had surgery or never had a proper surgery, and therefore look like they're N0 on a database, but probably would have had disease if a surgery had happened. What's also interesting and is not as commonly understood in a large-scale study is the breakdown of where these metastases happen. We always see a disease that's gone to other locations, but far and away, lung is the most common site for thyroid cancer to land. Nearly 63% of the known distant metastasis sites were in the lung. A surprisingly high percentage, 32% of known M1 sites spread to bone. But the other sites, including brain, liver, were quite low. And I think this is instructive. I have colleagues who sometimes insist upon an MRI brain for all of our higher risk thyroid cancer patients, but by and large, it's pretty rare and not something we typically see. So this matches with my practice and hopefully matches with yours as well. 7% of cases have multi-site M1 disease as well. All right, so this is where it gets a little more interesting for lymph node disease, because we wanted to use statistical measures to quantify the degree that each successive lymph node increases the chance of metastasis. We used a continuous multivariable regression model looking at the odds ratio of distant metastasis with each additional node. It's pretty impressive. Some patients had as many as 50 to 60 metastatic lymph nodes. But in general, I think the 0 to 20 range that I've listed here covers the lion's share of patients. If we look at well-differentiated and tall cell, you can see the curves continuing to rise with increasingly heavier lymph node burden. The more high-risk ones, poorly differentiated and anaplastic, were not so impressive. You can see that, in fact, each successive lymph node really led to no change in the odds of developing distant metastasis. Diffuse sclerosing was sort of an outlier as well. What this suggests is that for the more well-differentiated or intermediate differentiated cases, every lymph node, in this case, leads to a 4% rise or risk added on of distant metastasis. Every lymph node in a well-differentiated case leads to a 6% or confers a 6% risk, additional risk of distant metastasis. Now you wonder, why are these very aggressive cancers not really showing any difference? You can tell just by the scale at which they begin at 0 lymph nodes. These guys are such high risk, aggressive conditions that lymph node burden really doesn't have much impact. They already come built in or baked in to have a high prevalence of M1 disease. Lymph nodes really just doesn't touch it when it comes to histology. So the translation is that each successive metastatic node increases the odds of distant metastasis by 6% for papillary and 4% for tall cell, but the other ones had no increased risk correlating with burden. If we look at it in an alternative way, we can look at well-differentiated thyroid cancers that are just baked into or diverged into separate groups by looking at these cohorts of 0, 1 to 5, 6 to 10, and greater than 10 lymph nodes. We see a significant escalation of distant metastasis with heavier nodal burden. But let's be fair, let's be honest, let's be frank. The absolute risk is still pretty low, single-digit risk. So if you look at the relative comparator from 0 versus 10, there's a 10x fold higher risk, but still the risk is not exceedingly high. And that's something where Dr. Urken or Dr. Shaha might change their practice and start looking for lung metastasis. Nonetheless, as we start to get to the extremes, we begin to see an escalating amount of lymph node burden. This is a recursive cubic spline plot, which accounts for all the other covariates found in NCDB. They include age, T stage, other social factors, and also whether the patient got radioiodine, and also the extent of nodal disease. It accounts for all of it, and also histology. So the anaplastic patients and the diffuse sclerosing histologies are accounted for. Once you adjust for all of them, lymph node metastasis is still a signal. It doesn't go away like in other multivariate analyses. It's a clear signal where the higher the number of lymph nodes, the higher the chance of distant metastasis. And this is actually a hyperbolic relationship, meaning over time, the more lymph nodes you have, it's not just 6%, 6%, 6%. It becomes 8 or 10 or 12% added risk, which by itself is fairly small, but cumulatively can lead to something fairly more common than you might otherwise think. We were asked by the reviewers not to just look at metastatic lymph node number, but to look at lymph node ratio. I'll be honest, I'm not a big fan of lymph node ratio. I'll tell you why in a moment. But I know lymph node ratio is becoming a more accepted metric in many institutions, so we included it as well, and I'll explain my reservations about this metric later. But whether using metastatic lymph node number or lymph node ratio, the probability rises. The idea of lymph node ratio comes from the idea that if you have a numerator which is positive lymph node, that is a heavy correlate for better survival. But by looking at lymph node number of lymph nodes examined, you are accounting for the surgeon quality, the institutional quality of the operation that occurred. The higher number of harvested lymph nodes correlates with better survival. And so this has been combined by other cancers, including gastric, breast, and colorectal, into a ratio where a higher ratio correlates to poorer survival. So many people have thought, why not combine? This is work done by Julie Sosa in a couple of JCO papers in the past 10 years. So I'm going to examine why lymph node ratio is imperfect. I mean, it's not a bad metric, but it is imperfect. With the baseline that a higher ratio of 0.7 seems to correlate with poorer survival. So here's an example of a typical thyroid cancer patient. And let's just say the true number of metastatic nodes hiding in the body, in the neck, is 5. So I think, as Dr. Urken and Dr. Shaha and myself know, there are a range or a spectrum of thyroid surgeons, and most guidelines, most guidance statements don't really account for, say, a low volume surgeon or a high volume surgeon. But I would argue, I would posit, and Dr. Urken and Dr. Shaha may agree or not, that the occasional versus high volume versus accidental thyroid surgeon will have vastly different ratios. So let's say you have the occasional thyroid surgeon who does maybe a few thyroid surgeries a year. The central neck is precarious for perhaps injuring parathyroids or the recurrent laryngeal nerve. And let's say they harvest 4 lymph nodes, and they found out of the 5 that were truly in the body, 3 of them. So the occasional thyroid surgeon might have a lymph node ratio of 0.75. Now, surgeons like Dr. Urken or Dr. Shaha, they'll get a high number of nodes, but they won't go radical, right? Because the more lymph nodes you take, the more likely you'll injure the patient or lead to complications with the parathyroids, et cetera. And so they might get all the lymph nodes, all 5 true lymph nodes, and now your lymph node ratio falls below the 0.7 cutoff. So somewhat different of a situation. Then you perhaps have the very aggressive thyroid surgeon who will go after every single lymph node that is available, even if it may not help the patient. Such patients, if they get, say, 25 lymph nodes removed in the central neck, probably have a pretty high chance of hypoparathyroidism. And we all know that those patients may oftentimes have sort of at least short-term miserable quality of life. Sure, they'll get all the lymph nodes, but now their lymph node ratio is 0.2, and such a patient will be considered low risk. And finally, you might have the accidental thyroid surgeon perhaps never intended to do a central neck dissection. They remove the thyroid and a metastatic lymph node hitches a ride into the specimen, and they'll think that they did a proper surgery, but maybe they only removed one lymph node, avoiding the central neck entirely. Now their lymph node ratio is 1.0, and they're considered a very, very high-risk patient. So same patient, different surgeons, and now your lymph node ratio can be skewed to the extremes. You may or may not know Sue Yang was a radiation oncologist at UCSF. She has a habit of saying things that are true, but perhaps not politically correct. She has commented before, we shouldn't design systems for the best of us. We have to design them for the worst of us. So in that case, lymph node ratio, given its high variance, may not be the best tool. I'm going to spend just a minute and talk about how lymph node burden stacks up across cancers. It's always instructive to see not just how lymph nodes and other metrics stack up with our own disease, but to look at others as well. Our group has looked at lymph node burden across cancers, across all cancers in NCDB and also SEER. There's more than 1.3 million of them that we looked at. I'll focus in on thyroid in a moment, but what we found is that one of the limitations of our study is that for young patients who are less than 55 or younger than 55 years old, 55 being the new 45, that lymph node burden matters little, especially if you account for radioiodine. And that's just because radioiodine is just so darn effective for young patients. So that's something that I'll talk about in a second. Whereas older patients, older than 55, the lymph node burden matters, but it's less so than, say, other cancers. The lymph node burden matters the most for other cancers, including pancreas and bladder. But anyway, if you look at the magnitude of difference as you increase the number of lymph nodes involved, thyroid cancer, for the older patients, you see some spread, but compare that to, say, head and neck cancer, where there's a much wider spread, and the mortality risk with higher number of lymph nodes is lower. And then the worst, pancreas, bladder, and renal, you see the mortality risk drops quite precipitously. Again, this is not about distant metastasis anymore, but again, you can connect the dots and think about distant metastasis as a surrogate. I'm going to head Dr. Shaha and Dr. Urken off at the pass and discuss some of our limitations. Not all of the thyroid cancer patients in this database underwent neck dissection. This likely underestimates the true nodal burden. Not all distant metastasis patients undergo surgery, because if you found it from the get-go, these patients might have been excluded. The truth is, though, most distant metastasis patients with thyroid cancer still have surgery so they can get to the RAI step. We don't have a lot of details about the type of disease captured, including volume and burden of disease. And then a big limitation that NCDB has for thyroid cancer is it doesn't record the size of the lymph node. We all know that a bulky lymph node is far more dangerous than a microscopic petty one smaller than a millimeter. And we also we're not able to record extranodal extension. And finally, NCDB probably misses the majority of patients with distant metastasis because it really only captures it at the time of diagnosis. It misses delayed spread that might happen a year or two later. The idea that central and lateral neck disease is not captured in NCDB is very interesting because N1A, which is central neck, and lateral neck, which is N1B, in the 7th edition or the older edition, immediately upstaged you to stage 3 or 4. So that's actually was a big deal where patients would, with any microscopic lymph node, would be immediately upstaged to a very advanced cancer. They'd say that they would have an advanced disease. On the other hand, with the current edition, central versus lateral neck doesn't seem to matter anymore. In most cases, for T1 to T3 cases, being N1 versus central versus lateral just places you at stage 2. Only if you get to T4A cases, where they're very large cancers, do you get to stage 3 or 4. And then they don't really care if it's central or lateral disease. It seems to be less of an issue. All right, so clinically, what would you consider high lymph node burden to translate into actual practice? Well, first of all, in 2024, there are many more systemic agents that exist that perhaps could be best employed early on while the window of treatment is still open. So if you see any actionable mutations like RET, BRAF, or NTRK, there's something you can do about it. It's not something that we consider palliative anymore. For patients with high degree of lymph node burden that you find on ultrasound, you could consider more extensive pre-op imaging. Dr. Shaha has been a big proponent and has taught us that such bulky nodes may not only need a CT neck, but also a CT chest to better ascertain if there's something going on in the lungs. We all know that our REI can be effective for lung metastasis. And so even if there's no obvious metastatic disease in the lungs, some endocrinologists and nuclear medicine specialists may increase the dose of REI in anticipation that microscopic distant metastasis is on its way. And so for our institution, usually we go to 200 millicuries of REI, which is not an inconsequential dose. There's a much higher risk of complications than toxicities with such a high dose. But hey, if there's a high chance of distant metastasis, then we need to address it properly. And then finally, for postoperative surveillance, we may watch things more carefully beyond just looking at thyroglobulin. All right, well, this is our thyroid cancer program. I wanted to summarize our conclusions. As part of probably the largest cohort analysis of distant metastasis cases to date, we found that there was an escalating nodal burden that independently intensifies risk of distant spread in thyroid cancer. This influence diverges when you look at aggressive variants, whereas tall cells seems to exhibit a similar pattern. The more aggressive ones, such as poorly differentiated and anaplastic, they already pose an already high baseline that is minimally affected by lymph node burden. This, in reality, seems to expand what current end-stage classification cannot. We can decipher risk factors underlying distant metastasis, and we find that this is important given its impact on whether a patient lives or dies. And finally, this may suggest that we need a deeper consideration of lymph node burden to augment the risk stratification. Currently, if you have 1 lymph node or 20, you're still the same stage, but perhaps that needs to change in light of this data. So I really wanted to say thank you to Dr. Urken and Dr. Shah for the absolute pleasure at getting up at 5 a.m. In order to present this work, which hopefully you find as important. Thank you very much.
Terrific. Alan, thank you. That was awesome and a great presentation on a really fascinating topic here. And I don't think one could approach this particular question without delving into a large national database. I think I have two very quick sort of procedural questions here, just related to interpretation of M1. First of all, do you know, and a breakdown on the demographics of this group, do you have a breakdown on the age in this population here of patients with M1 disease? Is that skewed towards the older population? Do you have that data? And also, do we know how metastatic disease was determined? Was it strictly on the basis of whole body scans?
Yeah, the first question, I believe, spread quite evenly, 50-50 if you look at the age 55 cutoff. So it's fairly split evenly between those two groups. The second question, it was usually clinically identified. They have a CM or clinical metastasis stage. So it usually was identified either through imaging pre-op or immediately post-op. So if there was some index of suspicion. The perioperative degree that NCDB captures this is often mixed. It's very vague. My understanding is that as long as they capture the patient's treatment interval, that includes radiation, chemotherapy, radioiodine, that is a standard that these coders have to capture. So I would expect that because most people discover they have distant metastasis at the radioiodine whole body scan stage, that this captures the majority, almost all distant metastasis patients on whole body scan before they start radioiodine.
Okay.
Mm-hmm.
All right. Perfect. So, Dr. Shaha, I'm going to ask you, and I think it might be a good idea for us to start this by kind of going up to 10,000 feet and ask you, before we kind of delve into the details of this analysis, how does this finding influence you in terms of your management relative to the other variables that are available to us as clinicians in interpreting risk of dying of disease, which is really what we're talking about here?
Mark, that's a great question. Before I answer the question, Alan, you did a fantastic job of analyzing a huge database. And I think, I'm very happy that right in the beginning, you brought some concerns about the analyzing the database. And I think these are important points. Now, answering Dr. Urken's question, I think if you look at it critically, it's not just the nodal metastasis. What Alan has done is analyze the nodal metastasis to the risk of distant metastasis based on the data that he has available. If he could make another 3 papers out of this whole database, looking at the size of the tumor, looking at the extrathyroidal extension, the extra nodal extension. So these are some of the other factors. And independently, he could divide the whole group into younger patients and older patients. We know very well, those of us who commonly do the thyroid surgery in young people, the nodal metastases are very common, and those are the patients who have high incidence of distant metastasis. Finding a distant metastasis in 30-year-old patient is not uncommon. At the same time, we tell the parents, don't worry. This disease is unlikely to have the same impact as lung cancer or pancreatic cancer or renal cancer. The biology of thyroid cancer is much different in young people. We identify it generally post-operatively, so you don't get that data in the national registry because they don't come with a nodal distant metastasis. They have distant metastasis, but we don't have an imaging study to prove that. When you give them radioactive iodine, because there are 10 positive nodes, you find the nodal metastasis. You see the blackout of the whole lung. At the same time, we can cure these people most of the time with radioactive iodine. So the biology of thyroid cancer is a little different in different groups. So the other prognostic factors are also very important. Luckily, they go hand in hand. Who gets the nodal metastasis? Larger tumors. Who gets the nodal metastasis? The extrathyroidal extension or bad histology. So he has analyzed one factor of the whole equation. And we could do the SEER database and you will find more or less the same answers. Just want to go back 1 or 2 other comments, if I may. We always look at the nodal metastasis having no major impact on the outcome. I think that is true in most of the low-risk patients. In the intermediate and high-risk patient, the outcomes are different. And Alan made a very nice comment at the end. It was just in passing that if somebody has 10 or 12 nodes positive, we call it N1, the same stage. But there is something different here. If somebody has 20 positive nodes, you know that he is going to recur. May not die of the disease, but he is going to recur in near or distant future, may need another operation, a second or third operation for the recurrent disease. Sujitani was the first person to identify the impact of nodal metastasis on risk stratification. Any node which is more than 3 centimeters, bulky nodes or more than 5 nodes was a bad sign. Now we understand that because now we are looking at the lymph node ratio and everything else, and we are now analyzing in detail the nodal metastasis. What is the size of the node? Is there extra nodal extension? As a matter of fact, there is a last year's paper from Mingjao Zheng. The lymph node metastasis, which is BRAF positive, has a worse outcome. So now we are understanding that the lymph node metastasis does not mean that it doesn't change the outcome. I think we learned that quite a bit. And Alan's data is very illustrative of this. I also would like to congratulate Alan for doing a thorough analysis of lymph node ratio. I think you illustrated it very well. It was probably while you were driving, you were thinking about the lymph node metastasis rather than the traffic in LA. And you came up with these 4 scenarios, which is very good. I think that is the same thing that we think of, that as to the lymph node ratio to be used as a major prognostic impact.
Yeah, thanks, Dr. Shaha. I also share Alan's concerns about the variability and the nuance of interpreting lymph node ratio. I find that an extraordinarily complex parameter here. And I really actually find your classification of surgeons to be quite entertaining. The accidental thyroid surgeon. I know that the first question I'm going to get my next clinic day is, are you considered a high volume or an accidental thyroid surgeon? Thank you for putting that nomenclature out into the world here.
I'm happy to contribute to the literature, if only in that way. Yes.
Don't worry, Alan. I already wrote a paper on that.
Did you put me under the accidental thyroid surgeon group?
You're a co-author, so I cannot analyze you.
Yeah, I do think there's one other variable. You allude to it in your discussion about, and this may include the accidental thyroid pathologist who we rely so much on their harvesting of lymph nodes from the specimen, which may actually go down to the least experienced, a PA or a resident who is given the responsibility of removing those nodes. So in any event, there may be a gross underestimation of the number of nodes that are harvested and a gross underestimation of the number of nodes that are positive. But having said that, Ashok, let me come back to the original question here. Where does this manuscript, where do these results factor into some of the things that Alan mentioned, which is your decisions regarding the need for radioiodine, your decisions regarding perhaps surveillance, even your trigger for doing more extensive imaging, whether even above and beyond our I-121, in order to identify distant disease?
That's a great question. And again, it brings down to what I said in the beginning, that it's not just one factor, it's the totality of the disease. Somebody comes with a large primary tumor, clinically palpable nodal metastasis. I have an index of suspicion, two things, that this patient may have distant disease, and this patient will definitely require radioactive iodine. So suppose somebody presents with a 3 centimeter node in the neck, and the primary tumor is still less than 1 centimeter, I'll be more inclined to do total thyroidectomy because I know this patient needs radioactive iodine now and in follow-up. And the thyroglobulin value is going to be very important in that patient. And one of the things that is very important, which Akira Miyauchi has published, thyroglobulin doubling time. And I think that is very important in the follow-up of these patients with bulky nodal metastasis to see what happens to their recurrence or distant disease. It is not uncommon in our practice that we don't see the distant disease on routine imaging, but the thyroglobulin keeps going up. The ultrasound is normal. We know that the thyroid bed is clean. There is nothing in the neck. So we immediately start thinking there is a silent or occult distant disease, which you may not be able to find on a routine chest X-ray or even the CAT scan. You give 200 micrograms or 150 micrograms of radioactive iodine, millicuries, and you will find the distant disease. So I think this is very important. His paper is very important to think about the biology of thyroid cancer, which we did not think before. We lumped all the nodal metastases as one group, but now we can sub-analyze the nodal metastasis in different types and different histologies. I just want to add one more point, and this may be a little more critic. I think it will be important not to include anaplastic thyroid cancer in this. It's a different breed. It's a different animal. And I think to use that in the analysis maybe may kind of sway you from one way to the other, especially the mortality.
I would like to say that I agree with you, Dr. Shaha. It's a fundamentally and histologically different condition. Because this data is large scale and multivariate, we've accounted for these extremes. We've accounted for the anaplastic histology. And this signal of lymph node burden still pans out. It still exists. We've accounted for young age. Even when accounting for young age, this signal still persists. If it were just a simple matter of younger patients being studied, this signal would still exist. It would exist on a lower scale, on a less burdensome scale, but the signal is still there. There's definitely a signal through the noise.
The only thing is the mortality would not be 50%.
That's right.
I think, that the beginning of your manuscript and your presentation, when you read mortality comes down from 90% to 50%, it can be scary to young people. It is not so.
That's why I cover myself by citing your paper, Dr. Shaha. Yes, the 50% came from Dr. Shaha's group. Let it be known.
Yeah. So let me circle back, Alan. So you mentioned that the database does not include E&E, does not include size of lymph nodes, and one other parameter, being that whether a lymph node is clinically evident or not, which has made its way into risk of recurrence here. And that's such an elusive designation of what's clinically evident for one surgeon or one ultrasonographer may not be for another. But so it sounds like your management of thyroid cancer really puts this parameter of lymph node burden as it's just in terms of total number of nodes at a very high level in terms of these postoperative management decisions. Is that fair to say?
Yeah, I would say it probably changes my management when I see someone with a high nodal burden in a couple ways before surgery even begins. The first one is our institution, at least our endocrinologist, has a low threshold to get CT chest imaging. She likes to get it a lot. And I used to question whether that was necessary. It is a non-invasive, low risk imaging modality. But as Dr. Shah has pointed out, sometimes it alarms the patients unnecessarily. But I think it helps our endocrinologists start to frame the condition for the patient. The second thing it likely makes me do, as Dr. Shah alluded to, is that with the higher number of nodes on imaging, the higher chance of recurrence. And so in many conditions, and thyroid cancer is probably one of them, your first chance to clear all the disease is the best chance. So I would, in a high nodal burden patient, perhaps be more prepared to do a more extensive dissection to clear all the disease, and perhaps alert the patient that there may be a higher chance of hypoparathyroidism, that we may have to extend the incision, it'll be a longer operation, a longer recovery. All these are smaller aspects and pale in the comparison of mortality and prognosis, but it may go a long way to, if we clear all the disease, to reassuring the patient and also hopefully avoiding a second operation or a third one.
Okay, so and just to be clear, your endocrinologist is getting a CT chest prior to the outset of treatment, prior to your surgery?
She is, yes. And I'll be very honest, I don't think it's guideline driven, but I think it helps her with counseling.
Okay. So I think one of the things that might be very helpful and is one could think of a whole set of variables that might skew this data one way or another. If we start to take some of the layers off the onion here, we talked about some issues related to how aggressive a surgeon might be that could really skew the number of positive nodes, the pathology variable, whether a lymph node dissection is done at all, how M1 disease is detected and when it's detected relative to being captured in the database. Can you sort of talk us through that in terms of which way you think this data would be skewed, and does it even out in the end? And it is what it is, but I think it might be helpful here. And obviously, I'm putting you on the spot to walk through this, but maybe if you could just comment.
Yeah, absolutely. This paper is imperfect. I think I said it from the beginning. I said it in the end. Many things in life are imperfect. I probably was an imperfect fellow. I can see Dr. Shaha maybe in his mind's eye
You are the
sometimes,
most perfect fellow we had.
perhaps sighing a little bit inside as I made my way through training. But of course, I was better for it, and I'm indebted to Dr. Shah for that patience. So I would love if you would be perhaps patient about this paper as well. I think from a 10,000 foot view, as you mentioned, this paper has impact, it has implications, and there's truth in this paper. Now, if we peel away the onions, yes, there are some key variables that are not captured by NCDB. One is larger lymph nodes. So if they're bulky, if they're giant, if they're enormous, that may supersede everything. That may supersede anybody with a like innumerable 10, 20, 30 microscopic metastatic nodes. So that may be something that this paper does not capture in entirety. The idea of extranodal extension, for those who are not familiar, it's when the cancer punctures or penetrates through the capsule of the lymph node, gets into the soft tissue. That is an emerging prognostic factor. It's a big factor in other cancers, and it's captured by most pathology reports for thyroid cancer, but it wasn't captured by NCDB. So for thyroid cancer, I would suspect that the impact of extranodal extension to be modest. I feel that we see E&E in a large minority of thyroid cancer patients that are advanced or aggressive, but no one really seems to bat an eye on it. No one really ups the amount of radioiodine or treatment just based on that. Now, probably because there are other factors that go along with extranodal extension that probably supersede it in importance. Other limitations of this paper, as you also mentioned, and I alluded to with lymph node ratio, is the quality of the surgeon and the quality of the pathologist. Now, these are things that a single institution or a prospective study would capture because there's usually quality analysis. Let's make sure the pathologist knows what they're doing. Let's make sure all the surgeons are on the same page about what levels to dissect. Many prospective studies, in order to qualify to enroll in the study, the surgeon has to maybe go through some training. They may have to submit a log of cases to show that, hey, they are an accurate and proficient surgeon. This study is very messy in some ways because it captures all comers. But in its messiness, there's a beauty, if I may say that, because just like Sue Yan from UCSF says, you want systems, or in this case, data that doesn't allude to the best of us. You want it to allude to the mean or perhaps the worst of us. And if the signal is there, even when you're looking at the worst of surgeons and the best of surgeons, then that signal perhaps matches reality. So that's why I would look at for NCDB. It's messy, it's imperfect, but when there's a clear signal through the noise, it should be taken, although with a grain of salt, it should be taken as a measure of truth.
That's I think a very, very valid argument here in the discussion. I'd be very remiss if I didn't comment on not only some of the vagaries. My head and neck pathologist, Dr. Bramwine, who's dedicated a fair amount of her brain space to the analysis of tall cell variant, among other things, but it occupies a significant percentage there. And some of the vagaries associated with that, I'm not even sure what the cutoff point was back in the time frame of your patient analysis here, whether it was 30%, 50%, or what. Do you happen to know what was the cut point was back then?
Right. The study started in 2004. It ended in 2016. Clearly, over time, as people became more attuned to NCDB, each year more and more cases were diagnosed. Either because the institutions that joined were greater, but also, as is commonly known, more and more people were being diagnosed with cancer, perhaps due to the higher availability of imaging, the higher awareness, and the higher rate of biopsy. I think if you're asking about tall cell, is that what you're referring to, the tall cell diagnosis? Yeah,
Yeah.
tall cell, I think 2008, 2009, 2010, it went from less than 20%, sorry, greater than 20% of tall cells in a cancer specimen to 30%, according to the WHO. I think it actually changed recently again in 2024 to have more stringent criteria. Instead of it being a size ratio of 2 to 1 to qualify as a tall cell, now they're or 2 to 3 to 1. Now they say it has to be greater than 3 to 1 under the microscope in order to qualify as a tall cell. So clearly the bar is being set higher and higher for tall cell. This may be in response to the fact that more and more cases percentage-wise are being diagnosed as tall cell. You've probably noticed this at your institution. We've definitely noticed it in ours. It may be just due to pathology is converging and being made more aware of the impact of tall cells. So pathologists are suddenly catching it that in 2004 they may not have. I definitely think there's a little bit of human elements, human factors to the true incidence of tall cell.
No question. Yeah. Let me ask you one before I throw this back to Dr. Shaha. It seems, and maybe I'm wrong here in interpreting how you're thinking about this nodal burden from a mechanistic and a pathophysiology perspective of adding one more lymph positive node to increase that risk of distant spread. Are you thinking about this, and again, some of this comes back to the simplistic view of biology from a surgeon's perspective, maybe my simplistic view of this cascade phenomenon of lymph node metastases predisposing to distant spread here. And as opposed to some of the more aggressive pathologies that have that risk baked in from the very get-go, that's poorly differentiated and obviously anaplastic have that baked in regardless of lymph node metastases. Can you comment a little bit in terms of how you're thinking about this? Is this just an indicator of aggressive underlying biology within that group of well-differentiated thyroid cancer, or are you thinking about it more mechanistically?
Are you asking me or Dr. Shaha?
You, Alan. Yeah.
Okay. Yeah, I think it's actually an interesting question. We've actually tried to look at this translationally, where what is it that you have a very indolent low risk disease that has such a high propensity to spread to multiple lymph nodes? Any other cancer where it's spread to lymph nodes, it's a bad sign, right? Oh, this is a bad actor. This is a bad actor. In thyroid cancer, the reputation of nodal burden is that it's not so much of a big deal. In fact, there seems to be more emphasis in the literature on not over-imaging people in thyroid cancer rather than to find every last lymph node. There have been studies well documented that any sort of elective central neck dissection will have a high chance of finding microscopic disease. But we, as experts, don't seem to get too excited about that idea, especially if the consequences is morbidity from surgery. So I think mechanistically, there seems to be very low barrier for nodes to jump from the thyroid to the lymph node. But the paradox, which I find fascinating, is that there seems to be a big barrier to go from lymph node to lung mets. So although the paper is about rising risk of distant metastasis to the lung, as you saw, the rates were pretty low, single digit, right? That's what I think on an absolute raw scale that should be emphasized. There's still not a high chance of it spreading in that direction. We've actually looked at single cell sequencing and RNA-seq of patients of their thyroid cancer itself and of the regional lymph node. And to be honest, the signal is not that different when you look at single cell sequencing. It seems like it's very similar. So I wonder if it's just that the lymphatics in the neck are just so rich. They're so variable. There are many different on-ramps and off-ramps, with 300 lymph nodes or more in the neck that are all interconnected, as opposed to say like, breast cancer where there's just like one on-ramp, right? And that's why when we do sentinel node biopsy for breast, we trust that node as sentinel, there's only one way through. Whereas for thyroid cancer, I think there are multiple ways for the cancer to spread. So that's what I would say, perhaps accounts for the biology of why we see so many patients with high nodal burden, but not necessarily high mortality risk.
Great. We have come up against the 9 o'clock hour here, the 6 o'clock hour out in California. I want to thank Dr. Ho for really an outstanding presentation and for a body of work that went into this manuscript that I think is truly outstanding. And I echo Dr. Shaha's congratulations to you and your team for having put this together. Dr. Shaha, as always, thank you for your wisdom, your insights, and your enthusiastic participation. And with that, we have to come to a close. Thanks everybody for listening, and hope you'll be back again next week to join us on the Tyro MDS platform here.